Hello, everybody. Welcome to today's event. My name is Christy Amobi, and I'm happy to be here with you today. Thank you for joining us. Today we have Dr. Stephen Davis with us today. He is going to cover superficial radiation therapy post-op for keloids, protocols, techniques, and outcomes. Dr. Davis is medical director and board certified dermatologist at the Dermatology and Laser Center of San Antonio. Superficial radiation therapy offers non-surgical treatment options to office-based dermatology practices to expand patient care for non-melanoma skin cancers, such as basal cell carcinoma and squamous cell carcinoma, and to reduce keloid recurrence post-operatively. In today's session, Dr. Davis will discuss his use of superficial radiation therapy to treat keloids post-operatively. He will also review his current protocol and patient selection criteria and provide several cases. Dr. Davis has performed more than 25,000 skin cancer operations and currently uses Xstrahl's radiant dual-modality treatment system to deliver non-invasive electronic brachytherapy and superficial radiation therapy. Dr. Davis will be available for a live Q&A immediately following the presentation. Just a couple of quick housekeeping items. This session is being recorded and will be available on our website if you would like to review it at a later time or share it with a colleague who was unable to join us today. After the presentation, we will be answering questions through the GoToWebinar chat window. If you have any questions at all, please go ahead and enter them at any time, and I will moderate those at the end of the presentation. And if you could also tell us a little bit about your role at your facility and give us a little bit of background, that would also be helpful. Again, you can submit questions at any time during the presentation. We have had a little trouble with Dr. Davis's video today, so I'm going to be helping advance the slides for him. The presentation is approximately 20 minutes with time for Q&A at the end. Thank you for your attention, and with that, I'm going to turn it over to Dr. Davis.
Well, thank you, Christy. I'm pleased to do this, and thank anyone who's giving up their evening wherever you are in the world to watch this. I hope that I can provide some useful information. Let me tell you a little bit about what I'm doing. I'm a dermatologist. I bought the machine about 5 years ago, and I've been very happy with it. I've treated hundreds of skin cancers. I'm very pleased. And for the last several years, I've been treating keloids. I do a lot of surgery in my practice. So the first part of it, of course, is the surgical aspect, to be able to excise a keloid and close it. And usually it's in a challenging area like an ear. That's the typical spot. Sometimes I have to kind of rebuild these things. So a lot of what shows is the combination of my interest in doing that kind of surgery, and then having the ability to use the Xstrahl device to follow up with radiation. Let me start with my first slide with keloids and protocol. As most of you know who do any kind of cosmetic procedure, you have to really ask yourself, if you're dealing with a patient that can make a good judgment, that can the field be satisfied the result where the benefit-risk ratio is positive. About most of the time when I see a keloid on an ear, I determine that that's the case. Recently, I had to turn down a patient because they had such a massive keloid. It pretty much enveloped the whole ear. This resulted from them going to someone who actually excised the keloid. It was a fairly small keloid. It was not followed with any Keloid injection, and as it grew bigger and bigger, it finally pretty much enveloped her ear. It's very rare. Kind of broke my heart to have to tell her that I had nothing for her, because I'm not capable of reconstructing an entire ear. On the other end of the spectrum, I had a woman today who came in who had 2 small keloids. Even though I had earlier in the day done an excision followed by radiation, I suggested that she'd be better off with just some Keloid injections. So basically, it's a benefit-risk ratio thing. All of you know how to do that. Of course, photos are very important. Good photo documentation. In our practice, we always consider a keloid cosmetic unless we can really make a case that it's a functional problem. In the past, I've had patients with, as many of you probably had, with keloidal scars or hypertrophic scars following chest cracking for a bypass procedure. And I've done very few on the chest. It's more difficult. The chance for recurrence is greater, whereas on the ear, at least so far, I haven't had any recurrences, so it's done pretty well. So basically, the protocol is that we go ahead and do the surgery in my office, and then the same day, for 3 days in a row, we treat it with SRT. If you look at the literature, and all of us have to derive our own protocols based on what other people do. There's no FDA-approved absolute protocol. Most people will tell you, even when they were doing it with the big machines, they would use anything from 12 to 18 gray in 3 or 4 fractions, up to about 30 gray total. Most of the patients I've done 3 fractions, 4 gray each, for 12 gray total, and I haven't had any recurrences. I've been lucky. The published recurrence rates after surgery vary all over, and with surgery alone vary all over the place. I would never ever do a keloid excision without. Well, in the past, I wouldn't even do it with Kenalog because I've seen so many Kenalog failures, but that's just my bias. But since I started doing it with radiation, then I've been much more likely to do it. One of the recent studies with a 70 to 100 kV unit like mine had about a 10 to 15 recurrence rate overall. Hopefully, on the ears, it should be much less than that, but you can never promise a patient that it's going to work. But so far, they've all worked. And by the way, for those of you that are dermatologists, IL Kenalog can be used as an adjunct for this, with or without 5-FU. In fact, a patient recently, I'll show you slides, had such an interesting and difficult keloid that even though I followed with radiation, I still did some IL Kenalog for him. I don't use topical PRP. Some people use that. I just not been a big user of PRP, so that's up to the individual. As a general rule, I probably won't treat patients under age 18. I've had teenagers come in with keloids, and I just shy away a little bit of it. They're not adults. Even though it's local radiation and it's targeted, it's still a little hard to build a case for doing something like that in someone under age 18. So I've had to turn them down. The other thing I won't do is if they have a keloid on the breast or near the breast, even though the risk should be very small, I'm not going to do SRT on a woman's breast, even though the risk of inducing cancer should be very small. So those are just some of my rules. So there really is no one consensus guideline. You can look at the literature and all day and see the different things. And I pretty much went over on a previous slide what I do. Today I had a woman who had a very, very large keloid on the top of her ear. It was very deep. And I think I got almost all of it out of it, but it's still a little bulky. Her, I'm going to go ahead and do 4 treatments rather than 3. There's very little additional damage possible with 4. These are pretty low doses. So in this particular patient, I'm going to do a 4th just so I can just give me a little extra reassurance that it's going to work. And on the ears, I will usually either do a 3 millimeter depth or a 4 millimeter depth. You'll see in a minute some photos of a patient who had keloids on both sides of the ear, and you can go through the pinna or the skin on both sides with 4 millimeters. By contrast, when we're doing skin cancer, sometimes we'll just treat the surface or 1 or 2 millimeters, but the ear seems pretty resilient. The cartilage is pretty resilient, and so the depth of treatment with keloids is greater than it is for skin cancers. This is what my typical prescription will look like. A radiation technologist will come in and do a simulation just like we always do. We try to get a margin all the way around the keloid if we possibly can. I use the SRT settings for this, even though with skin cancers I usually use EBT, but most of the data is with SRT, so I use SRT for keloids. A depth of 4 millimeters or 3. We usually do 3 fractions. You can see the field size applicator might be a 4 centimeter applicator, might be smaller. It just depends on what you're doing. And so this is the way we build our prescription. Those of you who already have this machine will know what these prescriptions look like. If you don't have a machine and at some point you want to get one, Xstrahl folks are nice at giving you templates. They can't tell you exactly how to do things, but they can give you examples of what other people have done. people like me who over time have developed their own templates and built their own methods. This is a woman, a young nurse actually, who had very large keloids on both sides of her ear. She had on both ears, actually, left and right ear. So here's an intraoperative picture of the back side. That's the very large lump, and it's tilted around. It had a pedicle. It was almost on the top, and then you can see the other side was on the pinna itself, the scapha. And so on the scapha side, I did as much closure as I could. I kind of pinched it down, but I really didn't feel like I could totally close it. On the top, on the helix, which is the left hand where it says immediately post-op, on the left-hand corner, you can see I closed that, and I took great care to contour the ear. So I have a closure on the helix. The next one where it says 2 days post-op, you can see it granulating in on the pinna. At 3 weeks post-op, now we started the X-ray treatments the same day, even though it wasn't bloody, but it was raw. It doesn't matter. It doesn't matter if there's sutures in. It doesn't matter if there's a graft in. The graft will still take. We did the 3 treatments. 3 weeks later, she looked good. Everything had healed, and at 2 months she was still totally clear. There was no, nice contour for the ear, very little scarring. So that's an example of a successful treatment on the left ear where this woman had these 2 very large keloids. But this is the same woman on the right ear, and you can see again she had a lump on the front, a lump on the back. Here I actually did a partial graft, and 4 weeks post-op, that was the pinna. That was the one from the back side. It was healing and fine. The grafts often crust over a little until they finally take. 5 days post-op, you can see what it looked like. 4 weeks post-op, it's looking pretty good. And then this is the same woman you saw before. It never came back. I saw her months later. It looks real good. So you had 2 very large keloids on both ears. In this particular case, we used a 4 millimeter depth. We did not irradiate one side and then the other. We irradiated all the way through the ear. Okay. This is a patient that I've seen for many times over the years. He is a skin cancer patient. I've done a lot of skin cancers. He happened to have this very large keloid on the left lobe. He didn't have a piercing. He just developed this big keloid. I'm not sure how it came about. He was a man in his 60s that just wanted to get rid of it. So you can see the lump. We went ahead and excised it. Now in his case, where it says intra-op, you can see how I had to kind of do it. I left a big notch in his ear, and I fixed that by extending it down and extending it up, and then using a little of that skin to do a graft. So it was kind of a composite closure with a closure at the bottom and a graft in the middle. And I just had to craft it so that eventually he had a nice contour. You can see the Xstrahl device applied to his skin. 6 weeks post-op, he still had a little bit crusting. 6 months post-op, he had a very good result. There was it's not a perfect ear, but it's a pretty darn good ear considering the big keloid he had, and he was very happy, and it never came back. So these are surgical techniques that some of you can do and some of you may not do. I haven't had cause to send someone to a plastic surgeon to reconstruct an ear. It's intriguing to think that maybe if an ear would be a big problem, that a plastic surgeon might be willing to reconstruct one for you. And then if you have the Xstrahl device, you can do the radiation, but that's that would be up to you. Okay, this was actually my first patient several years ago. This man had used expanders in his lower lobe to keep enlarging the ear. That's just something he wanted to do. And eventually he formed this very large keloid dangling off of this opening. And you can see a couple of pictures, the first one on the left and the one next to it. So the first thing I did is I cut off the lump. And it looked pretty weird. But I managed to reconstruct it so that it closed nicely. You can see the picture on the far right. And then we did the SRT treatment. And 4 weeks post-op, it did well. And this is much later, did well, and I saw him not long ago. It looks the same. It's been a couple of years, and it hasn't come back. So these are examples of doing different kinds of surgeries that I can do and follow up with radiation. And let's go to the last slide here now. Let's see here. This is a man I did recently. I don't have good follow-up pictures. His ear was pinned down to his scalp. I can't remember the circumstances. This might have been previously surgically treated, actually. And when it healed, it pinned his ear against his scalp. So in the center slide, you can see how I pulled the ear back and tried to recreate a sulcus behind his ear, between the posterior scalp and the ear. And I did a little of this, a little of that, and it closed very nicely. In the far right picture, there's actually, you can put your finger behind this and actually it lifts up a little. It's not perfect. But today he was in for suture removal a few days ago, 6 weeks later. It looked just like this. And even though you couldn't fully pull his ear forward, it's a vast improvement over what he had. He's very pleased. So this was this was another example of what we do. So those are the slides I have, and I'm happy to field questions, answer questions about anything you'd like to ask if I have any takers.
Okay, thank you, Dr. Davis. I appreciate it, and I know. Thank you again so much for doing this evening for us. First question coming in is around the side effects, Dr. Davis. What side effects have your patients experienced?
The radiation, for those of you that aren't familiar with superficial radiation therapy, I'm very comfortable telling patients that there should be no internal side effects at all. Absolutely not, because it's the whole thing only travels a maximum of 4 millimeters into the tissue, and if it's into the ear, then there's no scatter because it's right against the skin surface. So that there's never going to be a systemic issue. In terms of local issues, when we do skin cancers, we can see discoloration of the skin. Sometimes we'll get a white spot that we don't like that lasts forever. It only happens about 5% of the time, but that's a possibility. Often we'll get a little bit of crusting after the treatments. But now these are people that usually have 10 or 12 or 14 EBT treatments, or sometimes 15 to 20 SR treatments. So little by little, and they get a lot more radiation. So they may get 40 to 50 gray total, where this is 12 to 16 gray total. So we really don't expect to see swelling or bleeding or puffiness or crusting locally, other than what you get with just the healing itself. So the biggest side effect, or the biggest potential adverse event, is failure to get a satisfactory result. And I tell all my patients that I do anything cosmetic on, that's always a possibility. But I think the chances of having any serious side effects with this on the ear are pretty remote. If somebody has a specific example of the kind of side effect they're asking about, I'd be more than happy to address it.
Okay, next question is around immobilization. How do you block the ear and immobilize it? We know the ear is floppy and pressure is needed to make sure the cone is sealed over the shielding. That's not easy to do on an ear. So do you have any tips?
My radiation technologist does that for me, and she has, all the standard materials that come with the Xstrahl device. So she'll, I guess I should have had pictures of it. Maybe that would have been something helpful. Maybe, I don't know if slide 8, if we go back to slide 8, whether that shows you. Yeah, it shows you shielding. Go back to slide 8 here, Christy. And you can see in one of the pictures the lead shielding around it. She puts lead shielding. She cuts the lead tape and shields it. So that's an example of customized shielding. And she's very skilled. It's not an easy thing to do. But Kelly's done this for years, and we always find a way to shield it. So again, it has to be customized for a patient. There's no one template that works for everyone.
Okay, thank you. Next question is around your treatment volume and how many of these types of keloids are you treating post-operatively in, say, a month?
Well, I've only, today I did one. I've probably done several dozen now over the last year or two. I didn't start until a few years ago doing the keloids. I've treated keloids forever, usually with injections with Keloid. But I probably have done, I'd have to go back, I've probably done maybe 12 or 15 patients, and some patients have had 2 or 3 keloids. But lately, I seem to be doing a lot. We don't advertise, but on my website, it mentions it in People find it. In fact, one of the things I have to guard against is feeling like I'm advertising for it. People will come in expecting to have radiation treatment for their keloids, and sometimes I have to tell them, like I had to tell this woman, it just won't work, or that I just don't think it's indicated, because it's a little hard to feel like, if someone has a really small keloid on an ear that you can shrink with Kenalog, that you can try to sell them $2,000 or $3,000 worth of treatment. So that, my experience is I have some experience, but I don't have hundreds of cases under my belt. I feel very comfortable about doing ears. Ears in general have a pretty good track record, regardless of whose cases you're reading. And there's some in the literature where people have, 96 cases among a group of doctors or something. So I expect our results are going to continue to be very good. I might point out that one thing's important, that you have to be sure when you do the simulation that the cone will really be able to envelop the whole keloid. Because if it's only going to, if it doesn't cover the whole field for any reason, then it's not going to work. And that's sometimes a reason why I might turn somebody down. It's just, you've either got to flatten out the helix if it's on the helix, you've got to pinch it down in the scapha if it's in there. You've got to be sure that it occupies the whole keloid. But in contrast to doing a skin cancer, you're not worried about spread of cancer cells, so you don't need a big margin, but you need enough of a margin to where you basically get the whole area that's been treated. So in that sense, it's a little less demanding in terms of how big an arc, in terms of how big a spot you need.
Okay. Next question coming in from a radiation therapist who's currently at a dermatology practice. Do you always treat to a depth of 4 millimeters, or does it vary due to the size of the keloid?
We treat usually 3 or 4 millimeters. I think we treat 3. I think because, we have our protocols. We treat 3 unless we feel like we need to do 4. 4 is the deepest we'll ever go. And 4 we'll usually do if it's very, very thick and we're not sure if we get the whole thing, or if it's through and through an ear. But I'll usually use either 3 or 4 because, like I said, we're only doing 3 or 4 treatments. So it's not as, if you do 3 millimeters on a shin and you do a bunch of treatments, you'll have nothing but problems. But on the ear, if you're doing 3 or 4 treatments to 3 or 4 millimeters, you really shouldn't have a problem. So I think you have a little bit more leeway. So usually it's either 3 or 4 millimeters. That's our protocol anyway.
Okay. Next question. Do you use superficial radiation therapy for any other indications?
Well, right now I'm not. I've been talking to the folks at Xstrahl over the years. And by the way, if anybody has a device, the people in London are happy to get on the phone. The medical director and others are happy to converse with you or give you some information. In theory, it could be used for a lot of things. It could be used for warts. It could be used for other, for benign disorders. And in fact, some people are trying to develop a modality. I think Xstrahl is even working on that. Right now, I've limited everything to skin cancers and to keloids. And some radiation oncologists routinely treat melanomas in situ with superficial radiation. You can do that. I've done a couple of them because I have the confidence that, knowing that if a radiation oncologist using the same amount of radiation feels comfortable doing a melanoma in situ with radiation, then I will too. But generally speaking, most melanomas in situ, almost all of them are still treated surgically. And I limit my SRT and EBT to basal and squamous cell carcinomas. In theory, you could also treat an AFX with that, atypical fibrous xanthoma. But the farther you get away from a straightforward basal or squamous cell, I think the more difficult it gets to be able to justify it.
Okay, thank you. Next question is actually about skin cancer treatment, so it's a good segue. How do you prevent white spots in skin cancer treatment? Do you lower the voltage down to 50 kV, or how do you address that?
Well, that's a good question. We're still struggling with that. We haven't had a lot of them. I've had maybe 2 or 3, and I don't like it when we get them. I don't think it's due to pressure. I don't think my technologist is pressing too hard on the skin. I'm not quite sure what the answer is, but when I'm getting them, and usually it's going to be on a forehead or a cheek of a light-skinned man, actually, for some reason. So what we would just do is just to double check to be sure we're not pressing too hard on it. And it's always safer if there's any question about what's going to happen to reduce the fraction dose a little bit and add a fraction at the end. We've learned over the years that the shins are so vulnerable to injury and so hard to heal that's one area where we'll be super, super careful. I mean, it's really helpful to do things on the shin because even an ED&C or any kind of surgery might take forever to heal over the shin. So instead of doing, 12 treatments, we might do 13 or even 14 and reduce the amount of grade for treatment. But I don't have I can't tell you definitively how to avoid. Oh, by the way, I will indicate. I do remember now. I wish maybe I'd shown this picture. I had a woman with very, very dark skin, a black woman, beautiful woman with very dark skin who had a very large keloid on her cheek, very large. It must have been, 2 centimeters long. And I excised it and I closed it in layers and did the radiation, and she never discolored at all. I haven't had any discoloration in black skin from doing this. You think that you might, because sometimes even a Keloid injection in people with dark skin can cause dyspigmentation or permanent hypopigmentation. But I just haven't seen that with rare patients that I've done keloids on have been African American. But as you've seen, most of these pictures, I think all of them have been light-skinned people. But I do feel comfortable doing even very dark-skinned people with radiation. I have no reason to think it's going to cause discoloration for them.
Okay, thank you. Next question. How do you charge for the procedure, and how much is a reasonable charge? Are you using a cosmetic fee or some type of specific SRT code? Is there anything you can speak to?
Yeah, everybody has to come up with their own fees and fee schedules. The first part is the surgery, and I'm a dermatologist and I do it in my office, and I think my patients probably get a pretty good bargain because some of these are very involved procedures, but I don't have to take them to an ambulatory surgery center. I never use, sedation, and everybody does things differently. But the woman that came in with the really big problem, she had a fairly small keloid, and they took it off at an ambulatory surgery center. The darn thing came back. So in terms of surgery, it just depends on what you want to charge for a surgical scar revision. And if you're a dermatologist and you do it, you have your own fees. So it may run anywhere from, if it's real simple, $600 or $700. If it's complex, you might want to charge $1,500 or $2,000. I have a feeling that sometimes I charge probably, I give someone what's probably a pretty good price and end up spending twice as long doing it. But in the case of keloids, I don't know. I feel pretty good about it. The rewards, the financial rewards are there, but I think that there's some things you do that are technically cosmetic, but you just feel that are a little more important. And so I tend to, that's the range. I would say $600 or $700 to $2,000 for a really complex surgical procedure, and or $1,500. And then the radiation. What we've done is we've taken the what we bill for our SRT session. I think we charge, I think we charge $350 for each treatment. So we'll typically charge about $1,000 or $1,100, I think, for 3 treatments. If I do 4, I often don't add that to the charge. That might be too little, actually. I just don't know. But if you get a young person in and they have a keloid on the ear and you charge them $1,000 for the surgery and $1,000 for 3 treatments, I think that's fine for us, and I think it's good for them. But that's just the way I do it. And some people may do it vastly different. Like I can't advise you on that and there are no codes you use. There are no codes you submit, and we never send these in for reimbursement. We don't even put a code on it. Nobody would accept it. So I hope that answers everybody's question.
Okay, next question. How many skin cancer patients do you treat a month?
Well, we see about 800 skin cancers a year in my office. I have a tremendous volume in skin cancer patients. And over the last 5 years, I've done about 800 individual skin cancers with SRT and EBT out of many, many times that more that I've either done surgery, ED&C. Sometimes I use 5FU in lieu of cancer. Sometimes I'll send patients to big skin cancer volume because I've been in practice so long. I've been in practice 40 years in San Antonio, which is a high sun area. So I have people that I've been following for 20, 30, almost 40 years for skin cancer. So, I have a big volume. I bought my machine. I like my Xstrahl machine because I'm the only one around that can do EBT. And EBT is quicker. It's every bit as good. In fact, it's virtually the same procedure. It's just because the focal length of the source of emission is a centimeter closer to the skin, you can do it in 10 to 12 sessions as opposed to 15 to 18 or 15 to 20, which is much better for the patients. And the reimbursement rates are good. It depends on where you are. I've had patients that had Blue Cross in North Carolina. They wouldn't pay for it in Texas. I've had patients in Texas where the Blue Cross plays very well. So it's just all over the board. And but Medicare and a supplement will usually approve it. The important thing is just not overusing it, because if I have a young, and this is a little maybe off topic, but I think the perspective is helpful. If I have a young man or woman who comes in with a basal cell on their clavicle or on their back, and they don't want a scar and they want radiation treatment and want me to charge their insurance for it, I just won't do it. I don't know if I have any legal obligation to do it, but I just won't. It's expensive. It's several $1,000s worth of treatment for them to avoid a scar. And if they do it, I say, I can't do it, and tell the insurance company there's an indication for it. If you want to do it for cash, then I'll charge you cash. And when you do cash, you pretty much have to charge what you charge the insured patient. Otherwise, you're undercutting the insurance company. So for the most part, for my patients, SRTs and EBTs for cancer are almost always done on patients over 65. We make some exceptions if they really, really need it. They're typically on areas where most surgery could be done, but it might be a little bit of a strain for the patient. Tip of the nose, top of the scalp where the skin is tough to pull together, an ear where you might have to remodel an ear, nasal sidewall, near an eye, shin. But for all other areas, I'm not really going to offer them EBT. Now, the other factor, of course, is whether they're on blood thinners, and because that can factor into it. Some people are just skin cancer surgery weary. I've had some Mohs surgeons in town that I work nicely with that have sent me patients that say, I've done lots of Mohs for this patient and they've been happy with it, but they just don't want more surgery. Can you do radiation on this? And I'll do it, and everybody's happy. So I think it's just important to not overuse this device. That's why I don't advertise, and it concerns me a little when people see advertisements saying things like, now you can get your skin cancer treated without any scarring and without any pain and so forth. And yes, they can, but I do think we have to use judgment because this is a wonderful treatment, and I don't want to put us in the situation of having overused it and and building up big bills for the payers. That's just my judgment. So everybody has to make their own judgment. But that's how I approach it in my office.
Okay, thank you. Just a reminder to anyone, if you have additional questions, you can go ahead and shoot those over in the GoToWebinar chat window. We have a couple more, and then we'll wrap up here. Next question is around your standard treatment protocol being 12 gray. Dr. Davis, do you know if there's any adjustments or changes to that if you were treating with a linear accelerator versus the Xstrahl system that you have?
I'm not an expert on that. I really don't know. When I review the literature periodically, and I'm thinking that people using other devices use the same amount, but I just really don't know. There's enough data on SRT where there are plenty of people that have used 70 and 80 and 100 kV units and used exactly that, 4 gray per fraction. And I know 4 gray per fraction is very safe because it's only 12 to 16 gray total. So that's, I have no idea what they use with linear accelerators. I know from personal experience, remember my younger brother, 60 years ago, had a keloid on his chest, and they used, they took him into a radiation treatment center and knocked it out. I have no idea what they use there. It's just, I don't know, because it's just not part of what I do. So I'm afraid I have to plead ignorance on that.
Sure, yeah, that's understandable in terms of your direct experience.
Yeah.
Final question here, unless anyone else has anything else, is around your success rates. You showed obviously cases that had been successful. Is there anything else that you can comment around your success rates in preventing recurrence?
I have the only recurrence I had one recurrence, but I'm going to give myself the benefit of the doubt. This is a woman, a really beautiful young woman, but it was a family friend actually, who had a small hypertrophic scar under her lower lip. Something had been removed and it had grown back, and it was like a hypertrophic scar. It wasn't a typical keloid. It was a hypertrophic scar, and I thought that I could do it, and so I excised it and closed it. It looked beautiful, and I did my typical thing, and it came back. So if that's a recurrence, then I've had one recurrence out of maybe 25 or 30 treatments so far. It's a little hard because it wasn't really a keloid, and I don't know whether the fact that it was a funny hypertrophic scar made any difference. So, my confidence is high that if you can really fully excise a keloid from an ear and get it down to cartilage so that you just know the whole keloid is gone and you're radiated, the chances are that very high chance it's not coming back. The only exception might be like today, where one was really thick through the helix of the ear. I got as much of it out as I could, consistent with not really thinning the ear out too much. And that's the case. I used a little extra oomph to a little bit. I used the four treatments with 16 gray. So I'm hopeful that there's enough radiation in that where if there's any keloid left behind, it will be stunted and won't come back. So I would, my success rate is high, and there's no reason why it shouldn't be at least 90% for any ear keloids you do, or even higher over a long period of time. But the other ones on the chest, I just haven't had the opportunity to do. I think I've done one or two of them, and I did one on the face, and I've done a few. I think I've done one on the jaw, but the ears I feel very comfortable about, and those happen to be the ones that are by far the most demand because of piercing.
Okay, thank you again. On behalf of Xstrahl, we do appreciate your time here today with us, Dr. Davis, as well as to all the attendees on the line. This session recording will be distributed to you via email, the email that you used to register for the event. It will also be available on our website if you would like to review it at a later time or share it with a colleague who wasn't able to join us today. Again, thank you, Dr. Davis, so much for taking time out of your evening. And with that, I will close today's session. Thank you so much.